Personally, I don't like to send patients home on nimodipine, and we typically don't do that. So if they go home in less than 21 days, we usually stop it. Occasionally, we'll stop it when they leave the ICU if it's less than 21 days also. Dr. Larson may differ. He really likes to continue the patients for the full 21 days in most cases. So I'll let him speak to that later. And in this monitoring and prophylaxis phase, I don't personally like to push the patient very hard with pressors, but we should at least maintain their intravascular volume. We want to keep the patients well hydrated. We don't want to let them get dry because that just puts them at increased risk for an ischemic event if they develop vasospasm. And we'll be behind the 8 ball if we start with a dry patient when we go into vasospasm. So I do think it's important to maintain intravascular volume and keep them well hydrated, but we don't necessarily have to push pressures during the monitoring phase if the patient is stable and doesn't have evidence of vasospasm. Then we use transcranial Dopplers, and we do them daily so that we can watch for trends. Sometimes these are difficult to interpret, and they can change when the patient doesn't really have vasospasm. Sometimes the patient has vasospasm and they don't change, so they're very operator dependent, and they can be difficult to interpret, so we have to use them in conjunction with the bigger picture and not rely 100% on CCDs. If we suspect that the patient may have vasospasm, either based on the TCDs or based on a clinical change, then we're likely to want to get a CT angiogram with a CT perfusion study. And if we aren't sure, or if we need definitive diagnosis or for treatment, as we'll discuss later, the patient may then go for a catheter angiogram. Okay, so once we've identified that the patient has vasospasm, now we're out of the monitoring phase and into the treatment phase. So what are the treatment options for vasospasm? The first and cornerstone of vasospasm management is hyperdynamic therapy, often referred to as triple H therapy: hypertension, hypervolemia, and hemodilution, which we really never have to do consciously because the patient's always managed to be hemodiluted by the time we get them in the ICU, or by the time we had them in the ICU for a few days anyway. And then there's endovascular therapy. And Dr. Larson is going to talk a whole lot more about this: intra-arterial myocarditis, or Rapidel, or angioplasty. And what is triple H therapy? How do we do it? So hypervolemia means we need the patients well hydrated. We typically use normal saline at rates up to 150 or even 200 cc's an hour. Basically, whatever the patient needs to keep them well hydrated, to keep their CVP, usually around 8 to 12 is our goal. Obviously, this is going to differ from patient to patient. And an elderly patient with a bad heart, we might have to manage a little differently than we do a young, healthy patient. Whether or not we use albumin or red cells is very controversial. We used to use a lot of albumin in these patients. Now we use it a whole lot less often. Personally, I don't like to use it very much anymore. There's a growing amount of evidence that albumin may increase the risk of complications and bad outcomes in critically ill patients. And so we don't use it nearly as much as we used to. We primarily use packed cells if we're trying to reach our ideal crit, which is 30 to 35%, where we can optimize the viscosity and the rheology of blood flow with the oxygen carrying capacity of the blood in this range. And then hypertension really becomes the cornerstone of triple H therapy. And as you guys well know, these patients often end up on more than one pressor. And we can talk about choice of pressors later when Dr. Copeland gets into the case discussions. I think that's one of his topics that he wants to cover, is how to choose which pressor to use when. And Dr. Larson is going to talk about that in his presentation some as well. Our systolic blood pressure goal here is going to be primarily dependent on the patient. And usually the goal is somewhere between 160 and 200. And we typically titrate the systolic blood pressure to the neurologic exam. And so the goal is going to differ from patient to patient, and we need to adjust it according to the patient and according to the neurologic exam, and it may differ from day to day. So this is, again, where vigilant bedside neuro-ICU nursing is the most important part of this patient management, because we literally need to see where the patient changes. The classic vasospasm patient can literally be hemiplegic with a blood pressure of, say, 150, and then when you push the blood pressure to 160, they literally start moving their arm again. And then when the blood pressure drops to 150, they're hemiplegic again. You push the blood pressure to 160, the hemiplegia resolves. So you know where that patient's critical blood pressure point is. So then you set the goal to keep the blood pressure over 160. 2 days later, that same patient might need a blood pressure of 180 to keep the hemiparesis at bay. And they may start to deteriorate with their blood pressure in the 160s and 170s, and we may have to raise the goal to 180. So we titrate the blood pressure goal to the neurologic exam. And that is the hardest thing to do, because everybody just wants to know, first thing in the morning, on rounds, what's the blood pressure goal, and they just want to write it down and be done with it. That's the goal for the whole week. Well, it doesn't work that way. The blood pressure goal may very well change as the patient changes. So we have to titrate the blood pressure to the neurologic exam. And I just can't emphasize that enough. That is absolutely the cornerstone of vasospasm management, is titrating the blood pressure to the neurologic exam. So I've also got some cases here we can go over quickly. Does anybody have any questions about any of that before we get into the cases? Oh, okay. So the first case is a 62-year-old woman who was found down unresponsive at home. She has a history of hypertension and was known to be non-compliant with her medications. She came in comatose with no eye opening, no verbal response. She had pupils that were 2 millimeters and unreactive, and a right gaze preference and head turn. She was withdrawing pain on her right side, had a dense left hemiplegia with an upward planned response. Her blood pressure is 225 over 120 with a normal heart rate. So what's the differential diagnosis? Stroke, ICH, subarachnoid hemorrhage, just about everything we talked about. But what's the most likely diagnosis, do you think? I think I heard somebody say ICH. Yeah, so most likely with blood pressure that high, a comatose patient, as Dr. Smith pointed out, the patient is hemiplegic and asleep, it's probably a hemorrhage. If they're hemiplegic and awake, it might be an ischemic stroke. And of course the topic today, or right this hour, is intracerebral hemorrhage. So this is probably an ICH. So what are we going to do next? What's the first thing we want to do? Well, don't forget about your ABCs. We've got a comatose patient, so we probably need an airway. We've got blood pressure that's really high. Regardless of what this is, we probably need to get that blood pressure down. And then we need diagnostic steps and work this patient up. So first of all, patient needs an airway. We need blood pressure control. We know that she is not a non-compliant chronic hypertensive, so we're not going to drop her blood pressure to 110. We're going to have a goal of about 140 to 160 for a patient like this, so we figure out what's going on. And we're going to get labs. We're going to look at coagulation studies in particular, and of course we're going to get a head CT. And this is what her head CT showed. So this was a spontaneous intracerebral hemorrhage with a focus here in the right basal ganglia and a lot of intraventricular hemorrhage. The right lateral ventricle is just casted with blood. There's blood over the left lateral ventricle. The third ventricle is completely plugged with blood, and the fourth ventricle is completely full of blood. And the temporal horns are dilated, so we have a little bit of hydrocephalus already beginning here. So what's the most likely cause of this patient's hemorrhage? Does this look like an aneurysmal hemorrhage? Probably not. It's probably hypertensive. But are we going to do some additional workup anyway? Of course. We're still going to get a CT angiogram. We're going to get an MRI with and without gadolinium to look for an underlying lesion like a tumor or vascular malformation. And so those studies are still going to be important, but it's probably just a typical hypertensive hemorrhage. And what are the best treatment options for this patient? Well, we talked about our hydrocephalus, so we put in a ventriculostomy, and normally we like to put ventrix in on the right side, but just because it's the non-dominant hemisphere and we're all used to doing it that way. But you can see this patient's right frontal horn is just casted with blood, so if we put the catheter in the right frontal horn, it's not going to work very well. So I put the ventriculostomy on the left side. Also, I'm already starting to think about the possibility that I might want to use some TPA on this patient, intraventricular TPA. And so I don't really want my catheter right next to the source of the hemorrhage either, if I'm going to use intraventricular TPA. And you'll notice that even after the ventriculostomy, this was follow-up scan the next day, or maybe even day 2 in the hospital, there's still thick cast of blood in the 4th ventricle and the 3rd ventricle. And so we did use intraventricular TPA for this patient. And this is another scan 3 days after the intraventricular TPA. And you can see that the blood is really clearing from the lateral ventricles. The 3rd ventricle is completely cleared. And the 4th ventricle now is completely cleared after just 3 days. And if you go back, you can see that the blood was not clearing, definitely not clearing from the 3rd and 4th ventricle after a couple of days of external ventricular drainage. So the TPA really made a big difference for this patient. And the patient did clinically improve as well. So here it is, blood cleared from the 3rd and 4th ventricles. And here's a late follow-up study 2 months afterwards, and the patient is recovered. Her hemiparesis is markedly improved, not completely 100% recovered, but she's moving that side very well, extubated, walking, and out of rehab at this point. And the follow-up scan shows that the actual focus of parenchymal hemorrhage and damage was actually quite small, and most of that blood was in fact intraventricular, and so clearing that IVH out allowed this patient to really recover quite well, and it also may or may not have helped prevent chronic hydrocephalus requiring a VP shunt. So this patient ended up not requiring a VP shunt, and there's some evidence that intraventricular TPA may decrease the need for VP shunting in some of these patients, but the verdict is definitely not back on that. How are we doing on time? Got time for some more cases? All right, so this next patient is a 34-year-old woman with a sudden onset of a very severe headache. She had no prior history of headaches or other past medical history. She was not a hypertensive patient, or at least not known to be. She presented with some nausea and vomiting. She was lethargic, but once we woke her up and stimulated her, she was oriented. She opened her eyes. She had appropriate verbal response. Her pupils are equal and reactive. She's following commands and moving all extremities. She does have some nuchal rigidity and photophobia, and her blood pressure is 168/82. So what's the differential diagnosis, and what's the most likely diagnosis in this case? Subarachnoid hemorrhage, right? Young lady, sudden onset severe headache, stiff neck. And so what are we going to do? What's the treatment? What's the workup? Obviously, control the blood pressure, first and foremost. She's young and healthy, and she shouldn't have blood pressure in the 160s, so we're going to get that down at least below 140 and ideally below 130, even into the 1-teens in a young, healthy person where you highly suspect an aneurysm. And we're going to obviously get labs, including coag studies. We're going to get a CT of the head, and this is really more for the frontline caregivers in the emergency department know this like the Bible, that if a patient presents with this story and their CT is negative, you don't stop there. This patient needs to go under puncture. With this story, this is a really, really suspicious story for a subarachnoid hemorrhage. So even if the CT is negative, you're going to get a lumbar puncture, and either way, you're going to end up with a CT angiogram. And then a cerebral angiogram catheter study for definitive evaluation. So here's the patient's CT. She did have a subarachnoid hemorrhage. She did need a lumbar puncture to prove it. And you can see there's blood in the suprasellar cistern, the anterior interhemispheric fissure, and the focus of the blood is primarily in the left sylvian fissure. And if you look carefully, you can actually see that there's kind of a filling defect, if you will, in the left sylvian fissure, where there's a little bit less blood right in this area. And that's because there's an aneurysm there. So the aneurysm actually shows up as a filling defect sometimes with a big subarachnoid hemorrhage. So this is the CT angiogram showing the aneurysm here, and another one over there. And here is the catheter angiogram demonstrating the left MCA aneurysm. This is a post-op CT scan showing the aneurysm after clipping. There's the aneurysm clip. The craniotomy, you can see the bone flap from here to here. And this patient also got a ventriculostomy. This is a typical post-op scan. There's a lot of hemorrhage in the sylvian fissure, and also this patient did develop some hemorrhage in the temporal lobe, probably from some venous congestion. We had to sacrifice some sylvian veins to get to this aneurysm, and she got a little venous congestion and had a little bit of hemorrhage here. This is typical subdural air following craniotomy. And I don't have all the films on this, but this patient did ultimately expand this hemorrhage a little bit, had some brain swelling, and needed a decompressive craniectomy. So we actually went back and took this bone flap off and extended it, as you'll see in a later CT scan. So anyway, here's what happened. So neurologically, the patient is stable at first. She's doing really well for the first 4 days post-op. She's waking up, following commands, moving on extremities. But on post-op day 5, she gets more lethargic and confused. Her speech is decreased and slurred, a little bit difficult to understand. And of course, she was a little agitated, so she got some Ativan the last couple of nights. And she's been getting IV fluids at D5 half normal saline at 75 an hour. And her blood pressure is, it's normal, but it's maybe not as high as you would want it if you were worried about vasospasm. And her sodium is 124. So what's going on? Why is she confused? Why is she more lethargic? Why is she confused? Well, there's at least 3 reasons right here, right? She could be in vasospasm. She got some benzodiazepines, and she's hyponatremia. And she could even have elevated ICP, but remember, she does have a ventricular. At this point, she didn't have any ICP problems. So what are we going to do? Well, we need to correct that sodium for sure. Hyponatremia is really not good for these patients. It's very common in subarachnoid hemorrhage. So we probably need to change her IV fluids. And what other studies do we need? Well, we might want to get a urine sodium. We probably want to get a CT of her head. We'll look at her TCDs. We might want to get a CT angiogram. So we did that. We changed her IV to normal saline. We want to hold the sedation to see if that was the main problem, and check her urine sodium. And then we reassess her. And now, a little bit later, she has a right hemiparesis with a pronator drift. Now before she was sleepy and confused, but she was non-focal. Now she has a focal neurologic change. She has a right hemiparesis. She's even more lethargic, and she even has some expressive aphasia. Her blood pressure now is 150. Her sodium has dropped. It's gone the wrong way. It's gone from 124 to 120. And her urine sodium is 150. So before we get into the whole picture, what do you think about this? What do you think about dropping sodium? What are the causes for hyponatremia? As most of you know, SIEH and cerebral salt wasting are the 2 most common causes for hyponatremia, especially in neurologic patients in the neuro ICU. And you might be tempted to fluid restrict this patient, thinking this is SIEH and the sodium is going down. We increased her fluids. We gave her normal saline, and the sodium went down. It's like, holy cow, maybe we need a fluid restrictor. Well, that would be a mistake. So we increase her fluid, we give her normal saline, we want to give her fluids. In the setting of subarachnoid hemorrhage and vasospasm, you absolutely do not want to fluid restrict the patients, even if you could prove that it was SIEDH. If you knew for sure it was SIEDH instead of cerebral salt wasting, you still can't fluid restrict these patients. They're extremely high risk for ischemic events if you fluid restrict them. And there was actually a study done more than 10 years ago, getting close to 20 years ago now, that demonstrated very clearly that hyponatremic patients with aneurysmal subarachnoid hemorrhage, if they were treated with fluid restriction, they had significantly higher rates of permanent neurologic deficits from ischemic events related to vasospasm. So you absolutely have to treat these patients with high volumes of normal saline to treat their hyponatremia. You can't fluid restrict them. And then we're going to get a CT of her head to look for rehemorrhage, to make sure that's not the problem. And because of the focal nature of her neurologic change now, we highly suspect vasospasm. So we're going to check the TCDs. We're going to get a CTA and probably a CT perfusion study as well, and likely head to cerebral angiography. And we're going to obviously treat this patient first with the Triple H therapy. We've increased her fluids. We're going to hit her with pressors. We're going to push her blood pressure. Our initial goal is going to be to get her up in the 160 to 200 range. Her blood pressure was in the 120s when she was first confused. It was 150 when she developed the hemiparesis, so we're going to push her at least over 160. We're basically going to keep pushing the blood pressure up until that hemiparesis resolves. And that's how we're going to find the treatment, the goal systolic blood pressure for this patient. And most of you probably know that we love systolic blood pressure over mean, but I'll just emphasize that even though the formula for cerebral perfusion pressure is mean arterial pressure minus ICP, when we're setting parameters and our goals for neuro patients, we really focus primarily on the systolic blood pressure over the mean arterial pressure for a number of reasons. First of all, that's really the pressure head that you need to overcome any intracranial pressure. So if you have high ICP and you're trying to perfuse the patient, the diastolic pressure really has little to do with how well you're going to perfuse past an elevated ICP. You need systolic blood pressure to perfuse past elevated ICP. If you have vasospasm, it doesn't matter what the diastolic pressure is, you need systolic pressure to force the blood through those narrow vessels. And in a setting where we're worried about rehemorrhage, when we're thinking about blood pressure parameters for minimizing the risk of rehemorrhage, again, it doesn't matter what the diastolic pressure is, the risk of rehemorrhage is going to be determined by the systolic pressure. It's going to be that spike of systolic pressure that's going to blow a clot off a little artery or off an aneurysm and cause a rehemorrhage. So the systolic blood pressure is almost universally the number that we are looking for in our goal, whether we're worried about rehemorrhage or worried about perfusion. And so we're going to use pressors to drive the patient's blood pressure. We're going to titrate it to the neurologic exam. And if the patient, for some reason, had a crit over 35, they won't for long when we hit them with normal saline at 150 an hour. And if the pressure, if the crit is less than 30, and they continue to have neurologic compromise despite the other measures, then we're likely to transfuse the patient. And this is controversial. Obviously, there's a lot of literature about the hazards of blood transfusion and the risk of ARDS and multiple organ failure and second hit theory and all that good stuff. But if the patient is not perfusing their brain, we're not oxygenating their brain, we're not reversing the neurologic deficit, we've got to do everything we can to get oxygen to the brain, and getting a crit into the ideal zone is likely to help. Obviously, we don't have good randomized controlled trials to prove this. We've got a lot of good cases, and especially a lot of good anecdotal evidence, and especially in cases where we've used Lycox brain tissue oxygen monitoring, we can really see the brain tissue oxygen rise after a transfusion when nothing else has been able to get it up. All right, so we did all that, and the patient did well. Her vasospasm resolved. I did mention that at one point she did need a deep compressive craniectomy, but 2 weeks goes by and she's doing real well now. She's been neurologically stable and not focal. She actually gets up to the rehab unit, and she's been improved. But after 2 weeks in rehab, her recovery not only plateaus, but she starts getting more lethargic. And she started to lose ground. Her speech is still intact. She's non-focal, but she's slow and she's confused. She doesn't have any paralysis. Her pupils are reactive. She's moving everything, following commands. She doesn't have any drift. So what's the most likely cause for this kind of delayed onset problem in a patient like this? Well, it could be multifactorial, right? She could be hyponatremic again. She could have had a rehemorrhage, although that's less likely since she's non-focal, or she could have hydrocephalus. So we get a CT scan, and lo and behold, she has delayed hydrocephalus. And you can see she did, in fact, have a decompressive craniectomy at some point also. And so this is always something that you have to have in the back of your mind. Just because we get them through the ICU and we wean them off their ventriculostomy, and their ICP stays normal with the ventric clamped for 2 or 3 days, and the follow-up scan after 2 or 3 days looks good, that doesn't mean that we're totally out of the woods. Sometimes these patients will develop late hydrocephalus 2 weeks after they leave, 2 months after they leave, even up to 3 months or more after they leave the ICU, sometimes after they leave the hospital. They come back to see us in the clinic, and they're just not improving anymore, they're starting to lose ground, and they can develop late hydrocephalus, so treat that with a shunt, and then after this she got her bone flat back and went about her merry way. And I think at that point, I'll probably stop. Does anybody have any questions?
Sure. What's the natural history of a VP shunt? Like, how long do these guys leave us in general? We never see that aspect of it.
That's a good question, and that's the reason that we don't put VP shunts in lightly is because we essentially leave them in forever. So we almost never take VP shunts out. It's so difficult to prove that somebody doesn't need their shunt anymore that we almost never take them out. And so we'll often leave the patient in the ICU with a ventric for up to 3 weeks, trying to wean them off their ventric before committing to a VP shunt, because we know that once we put it in, it's typically a lifetime commitment. With the new programmable valves, you can titrate the pressure up to the highest setting, and there are even some valves where you can technically turn them off. They're still not totally off, but the setting is so high, like 40 millimeters or 40 centimeters of water, that it's essentially off. And then you can watch the patient and see if they tolerate having their shunt set at such a high setting that it's essentially not working, and then you can go take it out. But it requires another operation to take it out. So not only is it difficult to prove that they don't need it, but there's risk in taking it out. So we usually don't take it out unless we have to. If it gets infected and we have some other complication where we find ourselves with the patient back in the ICU on external ventricular drainage. So suppose they get a shunt infection, 2 weeks later they come back, we take the shunt out, we put them in the ICU. Now we have an opportunity to test them again. We can try to, while they're on EVD, we can try to wean them off the external ventricular drain and maybe opt to not put the shunt back in after the infection is cleared. So sometimes we get an opportunity to try to get rid of the shunt because it gets infected. But otherwise, if you don't really have a good reason to take it out, we almost never take them out. So it's a big decision. Patricia?
I have a question. If you could just talk a little bit about differential diagnosis in aneurysms. If you don't see one on CTA, the difference between CTA and MRA, what's the role of MRA in there?
Well, MRA is almost as good as CTA, and it depends on your machines and your facility and your radiologist and your protocols. So for a while, our MRAs were better than our CTAs, but currently our CTAs are a little bit better than our MRAs. So we typically like CTA better, our CTAs are now so good that we, in emergency situations for sure, and sometimes even